doing on HIV prevention needs estimates. Today's workshop is going to focus on Eastern Europe and Central Asia. This slide is just providing us some quick housekeeping rules. We are going to share the slides from this workshop with you all, and we're going to share those slides together with the recordings, and we'll try our best to do that as soon as possible. I would like to encourage ourselves to engage during this workshop. Let's make it a very interactive session. There are two ways of doing that. We've got a Q&A function set up in this meeting. You can post your specific questions there. If you've got general comments or reflection comments you want to share with the group as we go through this workshop, feel free to use the general chat function. Let's separate actual questions from feedback or reflection so that it's easy for the panelists to track your questions and respond to them as we go through this session. I'm excited. It's the last of this series of workshops today, and I'm looking forward to a very interactive session today. So these HIV prevention needs estimates workshops, we have got four main objectives here that we are trying to achieve through these workshops. The first is to explain strategic directions for prevention in a new context, looking at the 2030 targets as well as the rationale for these estimates. The second one is to familiarize us all with the new spectrum needs estimation suite of tools. Then to share basic information on more detailed needs estimation tools, including for estimating PrEP need, for estimating condom need, and then in other regions, other tools apply. Then finally, to discuss implications for target setting and the use of these estimates for either national planning, global fund, GC8 processes, as well as any other process that could be relevant in your country. As highlighted earlier on, saying this is the last of the series of these workshops. We have done all those ones ticked with a green on the top right corner table there. And today, focusing on Eastern Europe and Central Asia is the last of these workshops. All the resources from these workshops are being posted on the Global HIV Prevention Coalition website. This is how our agenda is looking like today. We hear our welcome remarks and opening and introduction from Eleanor, who is with the Data for Impact team in UNAIDS. She's going to provide us a link between the estimates process and the prevention needs process that we're going to be focusing on today. For some of you who are involved in the regular estimates process, you'll be familiar with that process. So it'll be good for you to see what is the link between these two estimates. Then Clemens, also from our team from the Global HIV Prevention Coalition Secretary, to provide us a link with the Prevention Access Framework 2030, looking into the targets and the rationale for these needs estimates. Then we'll hear from Avenir Health. Rob, who is around here in place for John Stover, is going to present on a detailed overview, functionality and assumptions of the Spectrum Prevention Needs Estimate suite of tools linking to targets as well. After that, we have a short Q&A session where we can reflect on those presentations. Then we'll go into detail into the specific needs, starting with the PrEP, how it is done and in Spectrum, PrEP needs estimates, and then also with a standalone tool that is known as PrEPit that some of you might be familiar with. We'll hear from Avenir Health for those two presentations. Then we want to go through an exercise because we want this to be as practical as possible so that at the end, you are going to be able to do this on your own, be able to see where do you find these estimates in the Spectrum Prevention suite of tools, how to run them, how to read the outputs, how to interpret them for your country. So we have an exercise about 30 minutes or so that will be followed by some reflection section. Then we are going to also look at condom as part of other needs estimates. We have condom as it is done in Spectrum, as well as it is done with a standalone tool called CNET. We are going to look at other estimates, looking into key population size estimates, which our colleague Elaine from Data for Impact team is going to provide us a quick overview on that. After that, we have some time to have some reflections of all these discussions, and they are linked to the Global Fund GC8 processes. And then here, if already some countries here have an idea about what could be the country support needs as far as these discussions are concerned, and also global fund processes are concerned. That's all, and that's how the agenda is looking like. And I want to hand over to Eleanor for some opening remarks in the absence of Fode. Over to you, Eleanor.
Thank you very much, Lysias. Let me just try to project my presentation. Can you please confirm that you can see the presentation and that you can hear me?
So we can see the presentation and it looks good. Yes, yeah. Right.
Great.
Thank you.
Thank you. Thank you, Lysias, and greetings to everybody. My name is Eleanor Hoos, and I would also like to welcome you on behalf of the Data and Evidence Department. Many of you attended the recent HIV epidemic estimates webinar where updates were provided on the spectrum model and a brief presentation was made on the new tool and spectrum to estimate HIV prevention needs. And so today is really an extension of that webinar, and we'll go into much more detail specifically on measuring prevention efforts. And we're really pleased to see you again. We also thank the Global Prevention Coalition for organizing these webinars. The prevention estimates are so important for much of the work that we do at UNAIDS. And of course, as Lysias said, have strong linkages to the new global AIDS strategy, the agreed targets for HIV prevention, and the global AIDS monitoring process. So firstly, the global AIDS strategy for 2026 to 2030 has been finalized and will be presented at the UN high-level meeting on HIV in June of this year to be adopted by the member states. And the strategy has a strong focus on prevention, which will be underpinned and driven by a set of agreed and concrete measurable targets. And these targets will be presented in more detail in the next presentation by Clement, so I'm not going to say much about it. But the member states will be asked to report on progress towards achieving these targets. And as you know, the prevention efforts have always been difficult to measure, especially since people can switch between different types of interventions during a certain period of time. But for the people working on the strategy, it was important to try and find ways to measure progress, and it was agreed to do it for the individual prevention interventions. So the aim of the webinar today is to propose the use of the estimates process and to introduce a new tool and spectrum together with the other existing tools to help countries estimate the denominators or the numbers of people that need to be reached for the different prevention interventions. And then the global AIDS monitoring process will be the framework that countries can use to monitor progress towards these targets. And here is an example of what that will look like in the global AIDS monitoring process. For PrEP, for example, countries will be asked not only to report on the number of people who have received PrEP during the reporting year, but also on the number of people who needed PrEP during the reporting year, from which coverage can then be calculated. And similarly for the other prevention methods. So this will be discussed in the webinar, and we hope that the tools and the information provided here will be useful to countries, not only for the GAM reporting process, but also for the country planning and for your other efforts. And with that, thank you, and back to you, Lysias. Thank you.
Thanks, Eleanor. I'll hand straight to my colleague, Clemens, for an overview of the link of this to the 2030 HIV Prevention Access Framework. Over to you, Clemens.
Thank you so much, Lysias. I'm sharing my slides on the Global Prevention Access Framework, which I need to say up front, is in the final draft stage, so it is not yet a final document, but we expect it to be launched within a month. Can you see the slides now?
Yes, if you can swap display settings.
Yeah, I'm swapping. Okay, I hope you
Yeah,
can
perfect. Yeah.
see the slides now.
Yes.
Thanks. So this framework actually elaborates on the global AIDS strategy with a specific focus on the target on primary prevention. And it comes at a time when we realize that the world's HIV response is at a tipping point. Where we still have the technological and programmatic opportunities to achieve the ambitious SDG targets for HIV, including a 90% reduction in HIV incidence compared to 2010, which is here reflected in the green line. But we also see that if we reduce focus on prevention, even if we keep treatment constant, we could go into the opposite direction and see rising HIV incidence again. The world vision of this new global AIDS strategy and the framework is that by 2030, every person at risk of HIV will have access to a prevention option that suits their need. Yet this comes at a very challenging moment of a funding crisis where we need to optimally use resources to achieve those targets. There is a couple of strategic shifts in the new framework of prevention from intervention-centered or pillar or population-specific to person-centered in a more holistic way, integrating more long-term options into a prevention method mix. So method mix is a new focus. Numeric annual targets being promoted in addition to the aspirational long-term targets that we've had before to make prevention more measurable on an annual basis. And the needs estimates we talk about here are at the heart of this. There's a transition towards one national prevention program with a sustainable country cost structure rather than different, often part donor funded projects with their own costing realities. Self-care models for prevention could expand, and the shared responsibility to pay. And again, all of these will benefit from understanding prevention needs precisely. The person-centered framework that underlies this framework has 4 dimensions. The first one is a behavioral dimension where, the focus is on knowledge, risk perception, understanding prevention options and related norms. Secondly, we have access platforms here as one of the dimensions, which is a systems dimension, basically. So how to have an optimal mix of, health platforms, new AI and virtual platforms, but also interpersonal outreach and private sector platforms. For prevention, we have, of course, the question of an optimal mix of prevention options where we have the basics like condoms and lubricants, needles and syringes for people who inject drugs. And then, of course, also other options, including the new prevention options in the space of ARV-based prevention, of course, where we had oral PrEP, but now also have long-acting options, the same for OAMT, with an increasing array of options that could be relevant. And then, of course, we have a 4th dimension here in terms of societal enablers and stewardship, where we need the optimal mix of different structural components of prevention. For all of those, we will need to prioritize, and the needs estimates help us determine the right mix of these person-centered dimensions of prevention. Now, Eleanor already showed you the overall targets in 6 areas, 16 top-line targets in the global AIDS response. One of them was 90% of people in need of HIV prevention using effective prevention options, and that is the target that you see here in the third columns. And in order to achieve that third column target here, which is the headline target for primary prevention, we need the prevention denominators. Typically, those are young people and adults in geographies with elevated HIV, and then key populations, sex workers, gay men, transgender people, people who inject drugs, people in prisons, across different geographies. And then, of course, for some elements of prevention like condoms or needles, people living with HIV are also an important population. For others like PrEP, obviously not. So we need to understand the prevention denominators to actually understand who do we need to reach with prevention, where we have a 95% target, and then of those 95% reached, if we reach another 95% with them with actual access, that leads to that 90% target in a cascade logic for people using prevention options. And then we have, of course, a 90% incidence reduction target, which remains unchanged. The needs estimates will actually enable us to put out quantitative targets at all levels, global, country, and district level. At global level, this looks like, a 40-20-20 target, which, led to this slogan here in the framework of 40 plus 20 by 30, a little bit like the 3x5 that we had for HIV treatment. The idea is 40 million people living with HIV accessing treatment, 20 million people globally using PrEP options, 20 billion condoms, 20% of domestic financing going to prevention. So the 20s here are actually the prevention targets, but much more important than these numbers at country level will, of course, be country needs estimates. And then countries could have a similar type of headline framing of those targets, again, with a treatment target, a PrEP target, maybe a condom target, and then, of course, also a domestic financing targets and the people-centered targets below here, with the key population prevention targets in the concentrated epidemic settings like we have mostly in Eastern Europe and Central Asia, also partners of key populations and other priority populations here. So in terms of a coverage targets of prevention, again, then leading to 90% use of prevention options and a 90% reduction in incidence in combination, of course, achieved with the viral suppression, 90% of people living with HIV being virally suppressed. So the main shift here is of course not entirely new, is that we have this high level framing that could be used at country level or at district or in this region, oblast level, whatever the units are, to actually frame prevention targets that are easily communicated and can be then achieved through local means. In the framework, we also have then, of course, a more detailed breakdown of these targets. Again, here you see here an illustrative country target table, how it could look like for these targets that we have shown here, with detailed targets here then for different populations and different interventions. We then have in the framework a new outline of trusted access platforms that could also be, and you see the table here to the bottom right corner, could be linked to those needs estimates for prevention. And then they could be broken down here by the different access points, whether that's health facilities or community or pharmacy-based settings or key locations or virtual spaces. The new framework has a prioritization algorithm that has five P's of prioritization: the right people, the right places, the right packages, the best platforms, and the right prices, all coming together. They will actually help determining that effective prevention mix that the new framework is organized around. Maybe one word on the place of these new prevention needs estimates in the context of other tools and modeling exercises. We have actually here um, the on top the prevention needs estimates in Spectrum, and this is really the main reason um, for this meeting and this workshop is that we have this new tool in Spectrum that routinizes annual prevention needs um, as part of the Spectrum estimates process, which is similar to what has been done for HIV treatment for a long time, that we estimate the number of people living with HIV, and from there we derived the 1990 treatment targets. Something similar is now also available in Spectrum for prevention in the prevention needs estimates, and we'll introduce that in more detail in this workshop. That does not replace all the other tools that are available in this region. Of course, many countries have used more detailed allocative efficiency models, like Optima was used quite a lot in this region, or GOALS or AEM, other models that do much more detailed cost effectiveness analysis and optimization analysis. There's specific tools like PrEP-IT, for example, for detailed PrEP needs estimation and planning, or a condom needs estimation tool, which provide more detail for specific products. They are not replaced. The intention is not to retire those tools at this stage. The intention is to have something much easier and quicker available on an annual basis as a routine for countries. So I'll end here. And yeah, hope we have good deliberations. And back to you, Lysias.
Thanks, Clemens. The third presentation is going to come from Rob from Albany Health. He's going to provide us with an overview of the prevention needs estimate suite of tools in Spectrum, after which we'll go into the specific and needs estimates. Over to you, Rob.
Great, thanks, Lysias. And could you please verify that you can see my screen?
Yes, looks good. Thanks.
Okay, great. So, hi, everyone. So now I will be talking about the new tool that we do have in Spectrum this time around that is intended to estimate need for different prevention services, like Clemens just mentioned. Those of you who've been on the HIV estimates webinars will have had a quicker look at this, and we'll talk about the tool in a lot more detail today. So the purpose of this new tool, as we see it in Spectrum, is to assist your country teams to estimate service delivery and commodity needs to achieve your targets for key HIV prevention programs. And this is really focused specifically on four areas, three of which we'll touch on here: condoms, PrEP, and key population services. The tool is also designed to make estimates for need for voluntary medical male circumcision, but that's less relevant in this region, so we won't be talking about it much here. And the approach behind these is to implement versions of existing tools that you may have used in the past and that Clemens just mentioned, but to implement simplified versions of those tools within Spectrum in a tool we call the Prevention Needs tool. And the estimates from that tool can be saved as part of your national Spectrum file. So there are the four components here. I'm going to skip over VMMC and just move straight to the condoms component, which estimates national need for condoms in different population groups, and it replicates need calculations from the condom needs estimation tool. But like Clemens mentioned, this doesn't fully replace that tool. It just focuses on one specific area of that tool, the needs estimates. And for more detailed analyses, the CNET tool is still available and can be used. The The next component we'll talk about is the PrEP component, and this again estimates need for PrEP by target population, and it replicates just the PrEP need calculations from PrEP-It. Later today, Nicole will talk a bit more about some of the other features that PrEP-It can offer. And last, we'll talk about the key populations component, which estimates the numbers of people who need services in traditional key populations. So this shows the layout of the condom needs tool, and the structure that you see here is shared in common across the various components that we'll talk about. On the left-hand side of the tool, the left-hand side of the interface, we have the different population groups for which condom needs targets can be set. So that includes couples, well, serodifferent couples, sex workers, men who have sex with men, people with non-regular partners, and so on. And in each of these tools, for each of those populations, we need to know what is the size of the population in 2025, and what do we project that population size to be in 2030, and then what is the baseline coverage of condoms in each of those populations. Next, we need to specify what the targets are for each of those populations. And in the case of condoms, excuse me, let me get a highlighter. In the case of condoms, we need a couple of other parameters in order to calculate how many condoms are needed by year. We need to know how many sex acts require protection in each of these groups, and what level of wastage do we expect. We don't expect all condoms distributed will be used, but so we do need some parameter that tells us how many are likely to be wasted. The key point here is that while all of these inputs that I've just stepped through, the population sizes, the coverages, and these additional parameters, while all of these are pre-populated in the tool for you, they can all be edited if you have different expectations about your population projection, different targets, or the like. And as you edit those, on the right-hand part, you'll see that the total condom required estimates, those will update automatically as you make changes to the inputs. So you can review the needs estimates here and also modify them based on any additional information that you have. This is showing the key population component, and again, this has a very similar layout. We specify on the left-hand side the different populations that we are calculating need for. Here, female sex workers, men who have sex with men, people who inject drugs, and transgender populations. And again, we need to know the initial size of the population and projected size of the population, what our baseline coverage is, and what our targets are. And based on those inputs, we calculate the number of people we need to reach each year in order to reach those targets by 2030. And finally, the PrEP need estimate or PrEP need component is a bit more has a bit more going on. Again, like we've seen in the previous tools, we have all of the populations specified on the left-hand side, as well as their current and future population sizes and current and target coverage levels. And from there, we calculate how many person years of PrEP are needed in each year from 2025 to 2030. But the PrEP need component also lets you specify the mix of PrEP methods each year. So of the PrEP clients in each population, what percentage of clients are receiving oral PrEP, the dapivirine vaginal ring, a 2-month injectable or a 6-month injectable. And by default, this is set up to have a gradual transition from oral PrEP to 6-month injectable over time with less use of ring and 2-month injectable. But again, this is all something that you're able to edit if you're planning to do PrEP in a different way. And based on those inputs, the tool will calculate need for PrEP for each of those methods by year. So as you've seen in each of these, we do have default values for all of the populations and coverages and these other parameters. And so I wanted to spend a little bit of time on where those information are coming from. So For the key populations, those population sizes are used across all three components that we've just looked at, and the inputs are based on the UNAIDS consensus estimates that have been produced over the past years. For adolescents and youth, and for adult men and women in the overall population, used by the condoms and PrEP components, those are based directly on the World Population Prospects, the latest revision from 2024. Data on condom use and unmet need for family planning that are used in the condom tool, those are coming from household surveys. Whereas data on pregnant and breastfeeding people and numbers of serodiscordant couples are coming from either directly from GAM in the case of pregnant and breastfeeding people, and in the case of serodifferent couples, we take the number of people living with HIV from GAM, but then use a model-based estimate to translate that to a proportion of people who are living in serodifferent partnerships. Similarly, this table is going through the sources of current coverage in the tool. Like I mentioned earlier, condom use is coming from household surveys, or in countries that don't have those surveys, we look at regional averages. Coverages of services for key populations are coming from the UNAIDS KP Atlas, or again, because these data are often sparse, we do lean on regional averages to fill in coverage levels of key populations if they're not available. And so as you're looking at the tool, this is something I'd spend particular attention on to make sure that it's as reflective of your country as it can be. Data on current PrEP use comes from GAM, and levels of condom use for family planning come from the household surveys. I'll skip the last two on circumcision coverage. Now, what you'll see in the tool for the target coverages of each component are coming directly from the global targets that Clemens and Eleanor have already talked about. So this is what you'll see automatically when you go into the tool. But of course, if your targets are different, you're able to edit those and get needs estimates for your targets. As far as where to find the tool, this is implemented in Spectrum Desktop, in the Spectrum web software, and we also have Excel versions that can be used. So if you do have Spectrum Desktop installed, you are able to access the tool by opening up your national Spectrum file and going to the Tools menu, and then pressing this More Tools button. When you do that, it'll open up a window that lists a bunch of different tools that Spectrum has in it. One of those is the Prevention Needs tool. Now, when you go to access this, you might notice that the button for the Prevention Needs tool is grayed out. That can happen if one of two things are happening. One is if you don't have any Spectrum file open, the Prevention Needs tool won't be accessible. The other is if you have multiple Spectrum files open, the tool will look at whatever Spectrum file you have open to decide what country's estimates to show you, so you need to make sure you have exactly one Spectrum file open. And this is just showing a screenshot of what the tool looks like in the Spectrum software itself. For countries in the region, you will see the three tabs at the top left here, the condoms tool, the key populations tool, and the PrEP tool. You can switch between those tabs to look at the needs estimates for each of those areas. And we'll talk more about each of those in turn later in the webinar. That's all right. Thanks very much. I will turn it back over to Lysias from here.
Thanks so much, Rob. We have a few minutes here for a Q&A session. Some have been posting your questions on the chat function. We've been seeing them. We can also allow you to speak. So if you show by raising of your hand using the hand function, we can allow you to unmute, and then you can ask your question directly to the panelists. We had a presentation on the link between these prevention needs estimates to the regular estimates process from Eleanor. Then a link to the 23rd HIV Prevention Access Framework that Clemens highlighted. It's going to be available soon. It's in its final stages. And then now an overview of the suite of these tools in Spectrum from Rob. Are there any questions for these three presentations or any reflections before we go to the next session? If you prefer to speak, show by raising of your hand, and then we can allow you to unmute. Or if you prefer to type your question in the Q&A function, feel free to do so. Then we can check your question there. Okay, I'll give it a few more seconds. You may raise your hand or you can type. If you raise your hand, we can allow you to unmute. Any clarifying questions so far? It would be great at the end of this workshop to be able to navigate these tools. For those countries that are going to be going through the Global Fund GC8 processes, this is going to be very useful for you to be able to quantify your prevention needs, be able to cost them as you put your request to the Global Fund applications, and be able to demonstrate how you obtained your prevention needs and how you costed them, which methods you applied. So it would be great to grasp something from this workshop. We want it to be as interactive as possible and also to be as practical as possible when we go to the next session. Okay, I don't see any hands and I don't see any questions in the Q&A function. The questions posted in the chat function have already been responded to. Regarding the use of different tools with our colleagues, we will also maybe further discuss that aspect when we go through the prep needs estimates section. Okay, without further ado, I'll go back to Rob and ask if you can provide an overview of the prep needs estimates within Spectrum. And then after you can give to Nicole to present on the standalone tool prep it. After that, we can go through the exercise. Over to you.
Great, thank you. So yes, we'll talk more specifically about prep right now. And so I will be focusing on the prep component of the tool in a little bit more detail, as well as the assumptions and rationale underlying the targets that it uses. And so again, this component of the tool is specifically designed to estimate the number of person years of prep needed to achieve your targets. And let's take a moment to think about why this is important. So looking at data that have been submitted to GAM, we see that almost 4 million people were reported to be on PrEP in 2024 across 100 countries reporting. And you can see the breakdown here. And when looking at that 4 million number, it's important to put it in the context of the targets that Clemens was talking about earlier. So prep targets and needs estimates in the software are calculated based on a sliding scale. So the idea here is that in higher incidence populations, we want to reach higher prep coverage levels. So you can see an illustrative graph of this sliding scale on the top of the slide here, where in this particular example, at a minimum incidence of 0, our prep coverage target would be 0. But as we reach towards a 2% incidence, we in the population that we're trying to reach, our coverage target would scale up to an 80% coverage target. And the specific minimum and maximum and incidence threshold varies in the targets by population. So the table here goes through what those maximum coverage levels are. So there are targets laid out for PrEP for young people and adults in districts where HIV risk is elevated. The coverage maximum target there is 80%. And there are similar maxima for female sex workers and men who have sex with men and for transgender women. For people who inject drugs and for prisoners, the maximum is 50%. And there's some population-specific considerations that go into that maximum. So for people who inject drugs, the maximum is a bit lower because in most countries, more than half of people who inject drugs are using safe injecting equipment. And so we want to deliver PrEP to the people who are still in need of prevention services, those people who are not receiving safe injecting equipment. Now, in each of these populations, the maximum coverage target applies if HIV incidence is 2% or higher. And then the minimum might vary. So for young people and adults in districts with elevated HIV, the minimum is 0.2%, while in key populations, we want to cover people as long as there's any incidence whatsoever. Now, the targets for young people and adults in districts with elevated HIV, just to note that those are applied separately for the 15 to 24-year-old population versus the 25 to 49 population, and for men and women across those age groups. So there are separate targets for four young people and adult populations. The other consideration that I haven't touched on here has to do with men who have sex with men, where the minimum target is 20% of the population. And there is an overall minimum threshold that's applied that we would like to reach 5 people on PrEP per estimated new HIV infection in a country. So that's all to say that there's quite a bit going on with the PrEP target calculation. The nice thing about the prevention needs tool that we have in Spectrum is that it works through these calculations for you to produce target coverage levels for each population according to these criterion. Now, and through these sliding scales, we come up with a global target of about 20 million person years on PrEP by 2030. And you can see the breakdown of that target across different populations in the slide here. Now, let's talk a moment for what that 20 million person years of PrEP can mean. Now, the analysis here looked specifically at female sex workers, men who have sex with men, and people who inject drugs, and looked at the impact of progressively larger allocations of PrEP across those populations. So each point in the graph represents one of these population groups, and the populations have been sorted from left to right by HIV incidence. So each point represents some country or district, and either female sex workers, men who have sex with men, and people who inject drugs in that district. So at lower scales, we would deliver PrEP to the highest incidence populations that we can reach. And as we scale up PrEP more and more, we get very rapid increases in the numbers of new HIV infections averted. As our volumes of PrEP available increase, we would start to reach into people who still have very high incidence, but we start to see diminishing returns as we reach into lower and lower incidence populations at higher and higher volumes. And so in this analysis at about the 20 million person years of PrEP point, we do start to see a leveling of the impact that could be achieved. And so that's one rationale that underlies the volume targets that have been laid out. Now, another consideration here is the cost of PrEP. And so in this analysis, at a cost of about $84 per person year of PrEP and a discount, and assuming that the lifetime cost of treatment was about $6,000 after taking discounting into effect, we'd expect that PrEP might be cost neutral at about the 15 million person years of PrEP volume, with an annual cost of about $1.3 billion. So that break-even point is the point at which we expect that PrEP would eventually pay for itself in terms of the amount of future treatment costs averted. Although one thing to keep in mind with this kind of take is that the price of PrEP is going to depend on the volumes delivered. At higher volumes, we may be able to secure lower prices for PrEP than we can at lower volumes. So there are a lot of considerations that go into the target here. Moving on to the tool, I showed you this just a little bit ago, but let's take another look at the PrEP component. So on the left-hand side, we have adolescent girls and young women, adolescent boys and young men, males and females above the age of 25. Then our traditional key populations, men who have sex with men, female sex workers, people who inject drugs, and transgender people, as well as pregnant and breastfeeding people. So the tool is set up to have 2025 population size estimates for each of those groups, as well as our projection for 2030, and our baseline PrEP coverage target, which has been pre-populated in the tool based on your GAM reporting. And then a target coverage level for 2030 based on the calculations that I just highlighted. And from those, we can calculate the number of people receiving PrEP in 2025 and project the number of person years of PrEP needed to reach those targets. Now, we've done this review with we've done this initialization with a lot of countries. It could be that for any one country, things are a little bit off. So we definitely would like you to take a look at how the numbers receiving PrEP across different populations in the tool in 2025 lines up with any data that you have for your country. If these look a bit off, that may mean that our population size needs to be updated or that our baseline coverage needs to be updated. And we definitely would like you to update those if you have information that suggests that the estimates are off, so that what comes out of the prevention needs tool reflects the situation in your country as best it can. And from there, that'll give you a stronger baseline for making future estimates of PrEP need. And of course, you can also modify the targets if you have national targets that are different from these global targets in order to get prevention needs estimates that align with your objectives. Like I mentioned earlier, the tool does model a PrEP method mix. By default, the tool is set up to assume that there will be a transition from PrEP being entirely oral PrEP at 2025, with a gradual transition until about 30% or until 30% of people are using oral PrEP, with a transition of more and more people to other methods. We don't assume oral PrEP would ever go away because we do expect that some percentage of PrEP clients will continue to prefer oral PrEP over other methods. We also expect that when people have access to more than one PrEP option, they may choose whichever works best for them and hopefully improve the effectiveness of the PrEP mix overall compared to only having a limited set of options for PrEP. But again, you can edit this PrEP method mix to align with whatever you're expecting the strategy to look like in your country. And so based on the PrEP method mix that you enter, you will see that there is a detailed breakdown in the tool of the person years of PrEP required for each of those methods on a year-by-year basis. And those will update as you modify the PrEP method mix. All right. And that is what I wanted to get through. So I think I'll hand it over to Nicole now to talk about some of the capabilities in the PrEP tool that's really designed not just to estimate need, but also other relevant quantities that Nicole will talk about. So thanks. Let's see if there's somebody. I do see Nicole in chat is not unmuted, so could somebody please give her presenter privileges?
Yeah, I see.
Great, thank you. Folks, see my screen?
Yes, you can see it.
Great, thank you. I noticed that somebody wanted to ask a question. Lysias, did you want to allow for that before I begin, or do you want to hold it till the end?
Okay, I was about to text to say maybe they can ask when you are done with the presentation, but since you saw it, maybe we can allow the person to ask that question and then we can go to the next, in case if it's linked to this presentation from Rob.
Sure.
Yes,
Sure.
Matthias, you may ask. Let me allow you to unmute. You see a prompt asking you to unmute. May you unmute and then ask your question? Yes, over.
Okay. Yeah, thank you. I have just one question concerning the definition of those populations. You gave the example of the people who inject drugs, and then you said, okay, the coverage would be 50% would be enough because some of those are using safe materials. And I wonder, because the it's not always that the person with the highest risk is most eager to take PrEP. So it might be that you have 50%, but those 50% are partly those with still safe or relatively safe materials, and others that do use unsafe materials, do not use PrEP, but you cannot see it in the 50%, right? Did you understand the question?
Yeah, I
Yeah.
understand the question. I don't know if Rob, you want to start, or I'm happy to comment, but go ahead.
I can comment briefly, but I might ask Clemens to step in, and I see that he's gone on video, so I expect he's anticipating to. Matthias, I agree with you. For the tool calculations, we are just putting in a coverage level and multiplying number of people who inject drugs by that coverage, and it doesn't take into account who is accessing what services. As you say, there's a challenge in making sure that PrEP gets to the people who most need it. And Clemens, that's where I'm wondering if you're able to come in on the thinking around that.
Thanks. So I think it's a good question that we've debated a little bit back and forth on whether it should be separate or not. In the end, I think for this global needs estimation, we felt, assuming that we could get to 80% of people injecting using PrEP in any setting seemed quite ambitious. But there have been in this discussion some voices who said, well, with 2% incidence, maybe, we shouldn't actually differentiate between the populations at all and just apply the flat 80% maximum target throughout. So I can see a rationale for that. And countries where we still have that high incidence could consider taking that route of just, offering PrEP to almost everyone. And I think your reflection on yeah, not always the people in greatest need using when there is greater differentiation is a valid one. So I think yeah, I think we have that flexibility, and as Rob will show in the practical exercise, I think we have even put it there to 80% as well, at least in one of the files. So I think there's flexibility and ultimately the country to determine on what the uptake, what the uptake in the end will be. But if you simultaneously scale up needle syringe programs, OAMT and PrEP, our thinking was that, maybe we wouldn't get to that high level of PrEP use in any setting. Of course, we don't have on the ground experience, to my knowledge, on such large scale PrEP provision yet, so we don't really know what saturation coverage is. So whatever we do is an assumption that will need to be tested by how far programs will reach. Thanks.
Great, thanks for that question. My name is Nicole Bellows. I work at Avenir Health, and I'm going to give a presentation on the Prep-It tool that Rob mentioned. Does some of the same outputs that the needs prevention tool does, but goes beyond and gets a little bit more in depth into PrEP, specifically with regards to costs and impact. So the Prep-It is the PrEP implementation, planning, monitoring, and evaluation tool. It was first developed in 2019, funded through PEPFAR and USAID through a number of projects, and has been further supported since under the Mosaic Consortium and some other donors who've helped keep it along since then. It's a decision-making and analysis tool with different interrelated modules. The primary focus is on target setting, but it also has features of cost forecasting, estimating impact, and commodities forecasting. This is what the landing page of Prep-It looks like. It's prepitweb.org. It's available in English and French. And to get started, you use the start button on the left. There's also a feature that if you've done a bunch of subnational estimates and you want to aggregate them on the right, which is used less often, but is useful for countries that do everything at like a subnational level. So several countries, primarily focused in Africa, but also in Asia and other places as well, have used Prep-It for a variety of reasons, often for target setting. There's also been for, global fund funding requests. And more recently, it's been used for the lenacapavir rollout, as well as for commodities forecasting. And I'll talk more about that. Similarly to the tool we've reviewed before, the Prep-It looks at priority populations for PrEP and tries to isolate down to the number of people who are in need of PrEP or the potential PrEP clients. And we think about the broader population size. And then in situations where they're prioritized in certain geographies, what percent are in those prioritized areas. We're looking at the HIV negative population, of course, so we're factoring in HIV prevalence. And then looking at the percent indicated for PrEP or those that are in need of PrEP based on their likelihood of exposure to HIV. And that's where we sort of start with our potential number of PrEP clients. In terms of methods, we have 4 default methods in the tool: oral PrEP, ring, CAB, and lenacapavir. These have some default estimates on costs and effectiveness, as well as like when they will be offered in your target setting period. But all these can be adjusted by the user. Users can also add a method. You have to enter in some data around assumptions on cost, effectiveness, et cetera. But it can be useful for new kind of forthcoming methods, like maybe the forthcoming monthly pill, et cetera. One feature of Prep-It is that it tracks clients over time. We do this based on continuation curves, where in month 0 is when someone starts PrEP, and then thinking about how long people stay on PrEP over time. And which times some people drop out, they may restart, et cetera. So this tracking people over time is a key function. Some countries have data on how long people stay on PrEP by different populations. Others rely on the defaults in the tool that are based on implementation studies that we have that's useful for people who don't have that information. There's a cost and cost effectiveness module within Prep-It. We've taken a focus on costing, looking at costs in 3 different ways. There's those monthly costs on the product, as well as potentially adherence support. And then we think about costs as visits, and we break them out into initiation visits and refill visits. And we can track then how many number of visits we are expecting and those different costs of those types of visits. We also then, you can include lump sum costs, sort of your above site costs that can be around demand creation, management, training, et cetera. So users can select which cost categories they want to include in their cost estimates, and they can input costs if they have this level of detail, or they can rely on the country-specific defaults that are based on the analysis of prior program cost data and then adjusted to healthcare salaries in other data sources that are provided. So there are country-specific defaults, but like the other tools, you can always make adjustments if you have better or more updated data. Then when you combine your targets with the costs, you can look at the cost per infection averted by PrEP and examine it by both method and population, and keeping in mind that these costs take into account continuation, reinitiation, what your visit schedule is like, and your plans on scale-up trends over the target setting period. PrEP-IT calculates the number of HIV infections averted based on the targets that you've set, and we do this using impact factors, which are the number of HIV infections averted per person year on PrEP. These impact factors are estimated using the Spectrum Goals model, and they're both country, method, and population specific, and also based on method effectiveness and the projected incidence in each of the populations. So as I mentioned, these can then be combined with the costing module to look at cost effectiveness if desired. Target setting is really where a lot of people use PrEP-IT for, and you have a couple of different options when thinking about target setting. The most commonly used is to set it based on coverage. So in PrEP-IT, coverage is the percent of the potential users in each priority population who will be actively taking PrEP by the end of your target setting period. So accounting for all the scale up of the program. This is not the percentage of population who's ever initiated PrEP, because as we know, people start PrEP, they may stop for a while, they may restart, et cetera. So this is trying to take all that into account and think about what percent who are actively taking PrEP at a particular point in time at the end of that target setting period. Another feature you can say is, I want to set targets based on coverage. And ideally, you might enter in the coverage of 80% or something like that, but you have constraints. And you're saying, but we know that we have a cost ceiling, or there's only so much product we have available. So you can also add in constraints, and the targets will then be adjusted so that those constraints are met. The third option is to just manually enter your targets, maybe through another process. You've set targets, but you're curious about what those costs will be, what the impact will be, or what, or you want to look more closely of like how the commodities will roll out month by month, and you want to put in your targets and get some estimates on that. So some users use it for that purpose. And like the other tool, you can specify your method mix when setting targets. So there are a lot of different tool outputs. There's your PrEP new, PrEP CT, total PrEP recipients. For each population method, you also know the total number of initiations you have and reinitiations, infections averted, cost per infection averted. And then also, like, if you've set a certain coverage and that coverage couldn't be met, the coverage that's actually achieved, and the percent of potential users who are expected to initiate over that target setting period. So a lot of different data points. There's an optional feature to disaggregate your targets down to subnational areas. And the commodities forecasting module shows monthly estimates of expected visits, amount of PrEP product needed, and monthly commodity costs. So I've really just touched on give you an overview of like what this tool contains. There's a lot of details that we've brushed over, but if you're interested in using the tool, there is a series of instructional presentations for each module and input that can be found on the PrepWatch page here. If you're using the tool and you have any questions, you can send it to prepithelp@avenirhealth.org. And we also have an online community of practice if you want to engage with other users and if you have questions for them. So I'll stop there. Happy to answer any questions. And thank you very much.
Thank you, Nicole. And colleagues, we have got some few minutes here for questions. Let's do that, after which we can have an exercise to be more hands-on as far as these tools are concerned. If you've got any question, feel free to raise your hand. We can unmute you. Or if you feel or prefer to type the question, you may make use of that Q&A function. Type your question, and then we can be following that function. Any questions, any clarifications so far on what has been presented? Any reflections? There was I think a comment from Georgie about the use of other tools in the region with the POWER colleagues. John responded to that. I think what's important there is to maybe do a comparison of the outputs from those tools and also outputs from PREPIT and see are there any huge differences or the outputs are similar. Maybe that's maybe a good exercise that the region could do, and also to just see what are the outputs. If you want to do a detailed analysis of your PrEP program, what other outputs do you get from the power tools that are not in the PrEPIT or Spectrum 2, or vice versa, and then from there see how you may want to engage the different tools. Any reflections on that also, or any other question? I think an important point also to emphasize here is the standalone tools are not meant to be replaced by the Spectrum suite of tools. As you can see, the outputs from Spectrum are not as much as the outputs from standalone tools. Standalone tools are good to inform your programs for doing program reviews because you've got more outputs that come out of there. You can do a lot of analysis. But the Spectrum suite of tools on prevention needs estimates, it gives you a very quick estimate of your prevention needs. And it's already incorporated into your Spectrum software that a number of you maybe could be familiar with. But the standalone tools still remain relevant as you want to go into more detail for your prevention needs and also your prevention program. Okay, I don't see any question here. Okay, I see a hand, but I can't see whose hand it is. Or Georgie. You can unmute yourself. Over to you. I send a request to unmute yourself, Georgie. You can accept and then you can.
Do you hear
Yes,
me
over
well?
to you. Yes, we can hear you. Yes.
Okay, perfect. Thanks a lot for the presentations. Very interesting work. So, as far as I understand, there will be a component embedded into the spectrum exercise on PrEP, and then countries are also welcome to use PrEP for more detailed outputs and analysis, right? So, I just wanted to ask whether, based on the experience of countries that have already used PrEP-IT, I'm wondering whether they complete the exercise independently, whether country X can start and complete the exercise in PrEP-IT on its own, and if not, whether the technical assistance is available and how countries should seek for it. I think Nicole mentioned the help part, but like in more like hands-on technical support if it's available for countries over.
Great, thank you for that question. Yes, the tools can be used independently, so you don't have to start with the prevention needs tool to work in PrEP-IT or vice versa. They are related, but they are separate tools. If one is engaging with PrEP-IT and would like some support, you would just use that PrEP-IT help to ask support. And on our end at Avenir, we would consult and make sure, assign somebody to do that and help engage with your program. So it's not unlimited, but there is resources available for us to help you through that process. And as well as there is a lot of online instructional as well that is also useful, but we are definitely available for engaging and supporting you through that process. Did that answer the question? Is there anything else you want clarified?
Yes, maybe I could add that it's a very good question, George, of maybe what next from here after this workshop for the country in terms of this exercise. An aspect I could add could be if the exercise is going to be linked with the GC8 process, maybe you want to go through PrEP-IT to quantify your PrEP needs as part of putting your proposals to the Global Fund. Also, we'll be trying to be coordinating a process on how to give countries support on that as well. I can give maybe to Clemens, my colleague Clemens, maybe if he may also want to add around that, if your question has got any link to the GC8 process in terms of quantifying your PrEP needs, costing it, and then putting it in the Global Fund proposals.
Thanks, Lysias. Well, I don't think I have much to add. I mean, there's discussion at the moment and it's being finalized, technical support modalities for funding proposals, but I guess it would be too early to promise any specific support around this. But if there is broader TA available, which I understand there will be, this could of course be included in principle.
Thanks, Clemens. So I don't see another question here. I don't see another hand as well. We may go to the next session. So this is an exciting part of this workshop, to be a bit more practical, hands-on with these tools. We're going to go through an exercise. In the reminder email that we sent in the morning, we included some information on how this exercise could happen. We shared some links to install Spectrum for those who didn't have Spectrum on their laptops, or for those who can't install. There was also an instruction around how to use the online version of the tool. We also added links to Excel versions of the prevention needs estimate tools. For those, maybe if it is too late or you're not familiar with Spectrum and you would prefer to use the Excel versions, it would be very easy for you to follow through the exercises. So we're going to go through that exercise in the next maybe 25 to 30 minutes, so that at the end, we are all able to navigate these tools. Where do you find them in Spectrum? Again, we have another overview of that. Our Avenir colleagues are going to show us how do you go to each of those tools, and how do you check what needs to be checked, what data input do you need, where can you change, where can you not change, how to read the outputs and interpreting them. So I'd like to go through that exercise that every one of us here, when we leave this workshop, at least we know how to navigate this on our own. We can then practice further. So to do that, I'll hand over back to our RNA colleague, Rob. If you may take us a walkthrough of that and maybe slowly so that colleagues can be following through on their laptops as well. After that, we're going to have a reflection on this using a Menti. So over to you, Rob.
Great, thank you. So I'm going to start out looking at the tool in the Spectrum desktop software. So hopefully you can all see that I have that open here. Now, right now I don't have any projections open, but I'm going to open up an example projection for Tajikistan. And it'll take a moment, and after that opens, we should see my projection name up here, and down in the bottom right, you can see just that one projection. So we want to make sure we only have one projection open. If you have multiple, they will all show up here. So that's the first step. We'll get a projection open, and I'm going to go to the Tools menu, and I'm going to click More Tools, and get this window that has all of the different tools in Spectrum. And you see the prevention needs tool highlighted here. I'm going to click that, and that takes me right in. Because I have Tajikistan's file open, the data that I see here is all specific to Tajikistan. And I'm going to focus on the prep tool since that's what we've been talking about in this session. And so again, we'll see the different populations, like one row for each population that the tool makes estimates for. We see our 2025 population and our 2030 population. We see our baseline coverage. And just to note that in Spectrum, we can always change how many digits of precision we see. And in this particular case, we have some coverage, but it's below 1%. So we do need to see a few more decimal places in order to show that. And we see our targets for each of the populations and our prep need. So that'll be the first thing that we'd want you to do in this exercise is just to look at what is there and make sure that it seems like it makes sense. Now, it may be that we haven't quite broken down the prep coverage across populations correctly based on the data that you shared. I believe that we've had to impute the population breakdown for the data that have been reported to GAM. And so if it turned out that actually there's been more prep in men who have sex with men than the folks like me who implemented the software thought, we could change that. So maybe it was actually 1% and not 0.1%. And you'd see immediately that the number receiving prep will change to reflect the edit that I've made. So we go from 22 person years of prep in 2020 and 2025 to 224. So take a look at the coverage estimates, and if they don't make sense, you can modify those. Also, take a moment to look at these 2025 populations because we may have this wrong. It may be that since we last pulled all of the data together on population sizes that there's been another population size estimation exercise undertaken. And as a result of that, perhaps we learned that there were more people who injected drugs than we thought. So maybe instead of it being 28,000, maybe it's 35,000. And perhaps at 2030, because we're starting out from a bigger baseline, we should anticipate that there will be more people who inject drugs at 2030 as well. And so you can go ahead and edit those if you have more recent information. And again, you'll see all of these estimates and projections of need update as you do that. So that's one component of what we'd like you to take a look at, reviewing and updating the estimates and targets to make sense. So for example, in this particular case, this comes back to the question that Matthias had asked earlier about what the target coverage among people who inject drugs out to be, given what we know about behaviors within that group. In this particular case, we actually do have the target set at 80%. Maybe it should be even higher. Maybe we think it should actually be 90% in this case. We can enter that, or we can lower it. So again, all editable based on what you know as expert about your country. And if we scroll over to the right, that's where we can see all of these inputs for the prep method mix. So a table for oral, a table for the percent receiving ring, a table for the percent receiving the CAB-LA 2-month injectable, and another table for lenacapavir. And you can see that by default, these are there's a shift to the point that at 2030, 60 or 70% of people are using the 6-month injectable. Now, it might be that you have data for your country that suggests people have an even stronger preference for injectables than these lay out. So maybe instead of a method mix that reaches 70%, we think it would reach 80%. So we'd want to update that. And here I can use an interpolation method from 2025 to 2030 to enforce that. And since I've raised that part of the mix in 2030 for people who inject drugs, I should also come back over to my oral mix and lower that to compensate. That way my prep method mix hangs together. And as I make those edits, I can take a look at these estimates of the number of person years of prep required for each of the different methods, and that will update automatically. And so hopefully that's clear. I did want to just take a moment and say that you can also use the tool on Spectrum Web. So I'm going to come back out for a moment. So if you're logged into Spectrum Web, you would see an interface like this, and the same idea applies where I can open a projection from my projection library, enter the tools, go into the prevention needs tool, and you should see the same tool. Now, one thing that you might run into is sometimes in the tool, it'll turn out that the default values haven't been picked up. That's easy enough to resolve because we can always just come up to Restore Defaults button, tell it that I want to do that for each of the tools, and then we can proceed the same way as I just walked through on the desktop software. So everything that you see that we just saw on the desktop, we can also see on the web, and we can also edit on the web the same way. I think that we wanted to just take some time to let you work through this on your own before we come back to for the Menti poll. I do see that there are a couple of messages in chat. I don't know if those are questions that we want to take here. I'm not able to see those right now, but maybe Lucius, you could take a look and see if those are questions I can answer.
So I just see one, somebody was just showing, can you open it in full so that they can see? The screen is a bit small. So if you can expand it a bit so that they can see. Yeah.
Yeah, unfortunately I can I can maximize the window, but it doesn't change the font size.
Yeah, yeah. Yeah, so there are also links to the Excel versions of this. If you are not familiar with Spectrum and you don't have Spectrum, and you want to follow on these aspects that Rob was presenting, feel free to open those links. Let me share those Excel files as well.
Yeah, and while you're doing that, if you go to the Excel workbook, it will have a very similar layout to what I've just shown. The main difference is that, well, one of the main differences is that because the Excel version sits outside of the Spectrum software, it doesn't know by default which country to select. So the Excel version does have a country selection option that you'll need to toggle to look at estimates for your country. And just to say, I don't know that Lysias's version has this, but we do have a version that has been translated to Russian as well, in case that helps anyone here.
Yes, if you can share, that would be great, Rob. If you can share that the Russian version, I think it would be
And
good,
let me,
especially for this group.
yeah, let me see
I've
if I'm able to drop that into the chat. I don't know if drag and drop works.
So colleagues,
Apparently,
I've pasted the tools in the chat. We have done now the prep one that Rob just highlighted to us. In the other session, we'll do the condom one, and we're also going to cover the key population also in the next session together with condoms. So feel free to navigate using the Excel version if you don't have Spectrum or if you're not familiar with Spectrum, to navigate those different parts of the tool. If you know the country data already, you can punch in the data, you can update those data input. It's good if you can then be able to navigate that, read the outputs, and be able to interpret them. We've got next few minutes to just follow those steps that Rob was showing us, and then we will reflect on this exercise before we do the last session of the workshop. If you missed a
just
step, feel free to show in the chat or raise your hand, and then we can help you out. Yes, Rob.
absolutely. And I've used a very high-tech method here just to share some prompts for things that you might look at. Do the 2025 sizes look right? Population sizes look right? Do the 2030 population sizes look right? Do your baseline estimates of the number of people using PrEP look right? And do the projections of need look reasonable? And as you're looking at this, just please try out making different changes to see how those propagate through the tool.
Again, if you are getting stuck, feel free to raise your hand. Feel free to raise your hand. And if you've got any question, you can post your question in the chat. We have a few more minutes, maybe about 10 to 15 minutes for us to finish the exercise, and then we can reflect on this via a Menti. Then we do the last session on condoms and key population size estimates. 10 to 15 more minutes to complete this exercise. Maybe 5 more minutes and then we can reflect. 5 more minutes to finish the exercise. If you are not sure about something, feel free to ask in the chat or indicate by raising your hand. We can unmute you to speak. It will be great at the end, especially for those who will be involved in the Global Fund processes, to be able to use these tools to quantify your prevention needs, be able to cost them, and be able to demonstrate in your proposals how you came up with the needs estimates, what methods you used, and how you costed them. And also for your program reviews, for any other country planning processes for HIV prevention. Rob posted there some very good quick questions there to ask yourself. Do the 2025 sizes look right when you look at the default values? Do the 2030 sizes look reasonable in terms of your targets? Does the baseline estimates look right? Does projected need look reasonable? If you answer no to those, maybe look into updating the data or play around the numbers and see how the outputs look like. Three more minutes, and then we'll do a Menti to reflect on this. 2 more minutes. Okay, we're going to go to our next part here. We want to reflect on this exercise through a Menti. I'm going to share my screen. Let's reflect on this exercise and also on what has been covered so far. From the beginning, we had Eleanor from the Data for Impact who shared with us the link between the regular estimates process and this prevention needs estimate exercise. Then a presentation from Clemens that covered the link with the 2030 HIV prevention access framework that is almost done, that you're going to or receive, and some of you might have seen drafts already for comments. And then there was an overview from Rob Avene Health covering what these tools look like, what they do, the assumptions, and how to find them in Spectrum. Then we went into specific needs estimates, focusing on PrEP. We covered how it is done in Spectrum, and then we covered how it is done with the PrEP-IT 2, which is a standalone tool. And then we had a walkthrough of the PrEP part of the tools in Spectrum. And we shared the Excel versions of the different tools for you to easily navigate through this exercise. So now we just want to reflect on all those covered content. You may go to menti.com and then you enter that code. If you're using your laptop or your computer, just go to www.menti.com and then you enter the code 44382492. Or if you want to use your phone, you can just scan that QR code and then it will take you to this Menti. We just want to reflect on this exercise. Yes, you can put a thumbs up. I see 1 thumbs up that I'm there waiting for the Menti. I see only 6 people registered for the Menti. We really appreciate your quick feedback on what has been covered so far. It's a very quick, short Menti. Yes, I see some thumbs up. I see people are joining. I'll give a few seconds for us to join so that we can go to the last section of this workshop on condoms and key population size estimates. On your computer, menti.com, and you enter that code 44382492, or you can just scan that QR code with your phone. It will take you to a link to this Menti. 30 seconds, I'll give 30 seconds. Yes, I see people are joining. I see thumbs up. 30 seconds, and then I'll go to the next slide. Would value your feedback, your reflection on this exercise. "15 seconds. You can scan that QR code shown on the screen here, or you can go to menti.com and you enter that code 44382492. Yes, I see thumbs up, thumbs up. That's great. Thanks for those who have already joined the Menti. We will also be available even after the workshop for any help going through the exercise or to navigate the tools in more detail, and we've got more time. Yeah. I see more thumbs up. We would value your feedback. How many? 12 people have joined. I'll give maybe 5 to 10 more seconds, maybe for those who are struggling to navigate to join Menti. 5 more seconds. You can just scan with your phone the QR code, or you can go to menti.com. When you go to menti.com, it will ask you to enter a code, and the code is shown on the screen, 44382492. Okay, so I'll go to the next question here. The first question, it says, feel free to still scan the code with your phone to join. If you've missed that step, the code is shown at the bottom here. Just scan that code and it will take you to the Menti. What surprised you about the inputs into spectrum prevention needs estimate? Now that we have done a walkthrough, we have also done it yourself. What surprised you about the inputs into spectrum prevention needs estimate? Okay, somebody says many sex worker, meaning the input data there, like what Rob was highlighting to say, check the default values. Does it make sense? Are they reasonable? Already someone here made an observation that the sex worker size estimate there maybe was large for the country. Okay. What surprised you about the inputs into spectrum prevention needs estimates? Those default values, the ones that you found them there already, was there any surprise? And realistic size estimates, okay. Okay, some, they were very reasonable. Okay, I'll give a few more seconds. I see there are about 16 people who joined the Menti. I'll give a few more seconds for you to respond. Okay, data, that's a very good observation. The data does not look correct. That's great to make that observation for your country. And as Rob highlighted, those values can be changed when you've got the updated data, maybe through your technical working group, your prevention program people, and your prevention data people. When you sit together, you can change those default values. You can change those default values and put the correct data. That's a very good observation. Few countries in the web version. Maybe at the end of the Menti, I can let Rob respond to that. Somebody's saying there are fewer countries in the web version of the two. Ambitious targets, yes, targets, also another great observation. Thanks for these reflections. Ambitious targets could also be adjusted as you discuss as a country, aligning with your global targets, but making realistic targets for your country. Prep for young people. Okay, they were very reasonable. Okay, these are very good reflections. Thanks for those who have responded. I'll give maybe 3 more seconds, and then I go to the next question. These are all great reflections, yeah. Anyone who still want to respond to that, I'll just give 3 more seconds and then we'll go to the next slide. Okay, I don't see another response coming. Thank you so much. Now, what surprised you about the results? Is the next question. What surprised you about the results? Great observations on the input data. How about the results? Anything surprising? Was there anything unusual? Was it something expected? Prep need in 2030 is 0. Okay. Okay. One reflection so far. Prep need in 2030 is 0. I'll give a few more seconds for us to respond on this so that we can go to the next session on condoms and KP size estimates. Oh, the results, they seem quite ambitious. Okay. Thanks for those reflections. Any reflection? I see we are 16 of us who joined the Menti. Any more reflections on the results? For those who managed to get to the results part to have a look. I'll give maybe a few more seconds and then we'll go to the next part. 3 more seconds to go. Okay. Yeah, thanks for those who managed to respond. Great reflections. And just to say, you have maybe more time now. We're going to share the recording. We'll share this slide. You can spend more time on these tools on your own to practice more and to be more familiar with how they work and how to make the input data within your prevention technical groups. You can sit down, update the data, run the tools for your country and interpret your results. I'm going to stop sharing. We have the last Menti at the end of the next session, also to reflect your overall view at the end of the workshop. We are now going to our next session, which is going to focus on condoms, another prevention need, condom needs, and then also size estimates for key populations. And for that, I'm going to hand over to my colleague, Clemens, who is going to present on the condom needs estimate. Or before Clemens, I'll give to Avene Health to show us the condom needs, how it is done in Spectrum, because it's also part of the Spectrum suite of tools. So I'll hand over to Rob to present on the condom needs estimates within Spectrum, and then Clemens will present on the condom needs estimates using the CNET 2, a standalone tool for condoms. So in that order, over to you, Rob, and then Clemens. Over.
Great, thank you so much. So, like Leslie said, I will be talking about the condom targets and assumptions as they're calculated in the Spectrum tool that we just looked at. And just to note that even though in the hands-on exercise I focused on the prep tool, hopefully you saw that we have the other tabs for the other components there, and you can work on those the same way that you are working on the prep version. Okay, so on the condom targets and assumptions, so again, like the other components, the purpose here is to estimate, in this case, the numbers of condoms needed to achieve targets for condom programming. So this is important because nearly 50 million condoms were reportedly distributed in countries in the region in 2024. And that's a good number to have in mind as we talk about what the target region at the regional level is. So We can look back at the household survey data that's available for the region to get a sense for where condom use um, condom use stands. And this is looking specifically at reported condom use at last higher risk sex in the household surveys in the region. Now, admittedly, some of these are quite dated at this point, but the overall picture seems like economy seems to be fairly steady, perhaps decreasing in recent years. Um, we're looking at values between, say, 25% and approaching 90%, depending on the survey and the time point that we're looking at. So a lot of variation, but not a lot of growth. Um, Condom targets in the global strategy are ambitious. They specify that 90% of people in need of prevention services use some prevention option, whether that's PrEP, PEP, condoms, NSP, or OAT, and that 95% of the estimated need for condoms is available and distributed, and that 80% of people we would want to use a condom at last sex with a non-regular partner. So if those targets were met, in comparison to in comparison to the 50 million uh, condoms estimated to have been distributed in 2024, reaching these targets would require over 900 million condoms distributed across population groups by 2030. So that's a really big increase. And so I just want us to have that in mind as we look at the needs estimation and how that works in Spectrum. So again, this is showing the Excel version of the tool, which you can grab through the chat. And like I mentioned earlier, this is broken down by the different populations that have targets set for them in the global strategy. Like our other components of the Spectrum tool, we need to specify our current and future population, our baseline coverage levels, which again will largely be based on demographic and health surveys if they're available, or regional averages if they are not, and our target coverages. And then I mentioned this earlier, but I want to touch on it again. We do need a couple of additional parameters to turn the number of people reached with condoms into the number of condoms that are needed to reach these targets. And that depends on an estimate of how many sex acts per year require protection in each of these populations. The assumptions that you see here are in common with the CNET tool and can be adjusted if need be. And similarly, we have a parameter that specifies what percentage of condoms we think will be wasted. Because if our targets are in terms of the number of sex acts to protect, we need to increase the number of condoms distributed to account for how many we think would not actually ultimately be used. And on this wastage target, this has been a bit of a question mark in some of the webinars on this tool because we don't have a lot of good data on wastage. So if you do have information about that, you can certainly enter that here. And in fact, if you have data on that, we'd be grateful to hear from you offline in order to talk through whether the data you have could be used more broadly to inform the kinds of estimates that we're making. But again, just like you saw in the prep tool, you can edit any of these inputs to align with your data and your targets, and immediately see how that translates into the estimated number of condoms that are required over the years to reach those targets. And so there are a few key considerations to keep in mind as you're looking at this. Just like we were talking about with prep and as came through the Menti, it's important to review all of the population sizes to make sure that they're accurate, with a special focus on female sex workers, men who have sex with men, and people who inject drugs, just because we recognize there is a lot of uncertainty around the sizes of those populations, and the sizes of those populations is going to, like any uncertainty around the population sizes, is going to translate into uncertainty around the number of condoms needed to reach targets in those populations. The second point is, again, it came through in the Menti that the targets are ambitious. We do recognize that condom use doesn't seem to have increased much over the period that we have surveys from. So it may be that as you're looking at what targets to put in, you think about what might be possible given the level of condom use in your country. The third point is less about what the tool does, but more about the strategy, how condoms factor into the HIV prevention strategy overall. We've been doing a lot of analyses over the past year looking at the impact and cost effectiveness of different HIV prevention programs. And we consistently see that condom programs come out as highly cost effective and sometimes often cost saving in terms of future treatment costs averted. And so we just wanted to emphasize that any deterioration in condom availability is something that we'd be really concerned about and expect could have some serious consequences for trends in new HIV infections. So I just wanted to end there and turn it back over to Clemens for the next presentation. Thanks.
Thank you, Rob. I will just be briefly speaking to the CNET tool, which is the condom needs estimation tool. You will find this available on the Global HIV Prevention Coalition web page. Maybe my colleagues can already share this while I'm pulling up my slides. I'll put that in the chat. Just taking a moment to pull this up and share. Hope you can see the application now. Can you see it in the right mode?
I do, yes.
Yes, yeah, looks
Okay.
good.
Yeah, so you see the link here. We can also put it in the chat. The CNET tool is actually the detailed original tool around which the spectrum needs estimation for condoms was modeled. Rob already provided some of the epidemiological context, and we know, of course, that for condom programs, a big part of the need is often covered through the private sector already, right? And especially since we have a number of upper middle income countries or low middle income countries in this region, we assume that for the general population, a large part of their need of condoms will just be covered by the market. So a strong focus of condom programs from an HIV programming perspective will be on key populations. And you see here from the UNAIDS AIDS info, again, not all very recent data, but sort of a pattern of condom use for sex workers and for men who have sex with men. We see it's a bit higher among sex workers, and there a benchmark is the 95% condom use, which is the darkest shading, which is achievable actually and has been achieved in several countries. And for men who have sex with men, you see a number of countries have achieved the 75% benchmark, which is the darkest shading in the lower part of the graph. So we see some other countries have gaps. So there is actually always potential to optimize. And I'm just showing this because the CNET's role and maybe also the role of the condom spectrum needs estimates would be to identify the total need and then really decide, is there scope for some public sector intervention for either condom promotion, on the demand side, or actually on the supply side, also some distribution elements, in addition to what is already happening through the private sector. So the main scope of the CNET and its application or the condom needs estimation tool in Spectrum would be to facilitate such discussion on where can public sector intervention or public financing intervention for condom programming or promotion be most strategic in making an impact on the epidemic. And part of that should actually also be ideally an analysis of inequity in condom in condom access. Sometimes we see actually differences not only by geography or by population, but also for, for example, by income level. So the CNET is not only a needs estimation tool, it's also a data analysis tool, a people-centered program design tool, a costing tool, and it sort of facilitates this catalytic process of bringing the different sectors together. So ideally, in using the information, whether it's CNET or whether it's the condom needs estimates or PrEP needs estimates from the Spectrum tool, it would be good to bring, the public sector, but also perhaps some private sector representation together and use this analysis, the estimation of the total need, to explore opportunities for program development or for market development. Here you see the configuration of CNET, which is the same as for the Spectrum needs estimation tool. That's why I'm not walking you through again. So it's an Excel spreadsheet with a number of detailed tabs. It has these functionalities to identify priority populations. It actually has a baseline validation facility that is a bit more detailed. So it estimates based on available use or other data the availability. It actually then helps set condom targets. And then what you have here in the box is sort of additional elements in CNET that are not in the Spectrum, which is the commodity mix, a male-female condom mix. Of course, vast majority being male condoms in virtually all settings, lubricant needs and so forth. So this slide provides, and we will provide this to you. It provides a comparison of the two tools. One consideration is the Spectrum needs estimates is pre-populated for virtually all countries, which is an advantage. The CNET has been primarily used in Sub-Saharan Africa, is populated for a subset of countries that have demographic health surveys or similar type of population-based surveys which are required for populating it. Yeah, so here you see an example of a demographic data sheet. Here you see examples of outputs here. So CNET actually provides a range of graphics, also annual target growth and output in relation to that, whether it's in terms of condoms or lubricants or cost associated with condom programming. Can of course be also used for Global Fund GC8. There's a user guide available on our webpage as well, and here you have the links. You will have that in the slides. And yeah, as maybe a recommendation, it is useful, particularly also since we see in some settings in Eastern Europe and Central Asia, we do see heterosexual transmission growing, and we do see spread of HIV beyond, the course original groups in the epidemic. For example, in drug user epidemics, we often see geographically elevated HIV prevalence, then also having a heterosexual transmission component to some degree, and it's therefore useful to actually have this condom needs estimation discussion here as well. Importantly, of course, that doesn't mean that the key population programs are not important. They're of course at the core of the analysis, and in that sense, of course, the condom needs estimation should also have these population specific estimates for key population. And perhaps the result will be of this analysis that the scope for public intervention or public health intervention beyond what the private sector market is primarily focused on key populations, but still considering those epidemiological dynamics, which you in your countries, of course, understand in much more granularity, it's useful to have a perspective on the full picture. Yeah, here you just have a number of additional attributes. So we can share, of course, all those materials and the slides. Maybe one final consideration on this integration of the needs estimates for condoms and PrEP in the spectrum suite. That's also an advantage of the, spectrum tool, that it sort of helps, making assumptions on all the different interventions, whether that's and populations, and that then often also shows the synergies. For example, we have seen in a number of countries where we have very high PrEP coverage that, for example, among gay men, the condom use and condom need goes down slightly because there's a replacement happening. In other populations, sex workers, for example, PrEP uptake is maybe in addition an additional safety net, while condom need remains high. So doing condom and PrEP needs estimates, for example, or same would apply to harm reduction needs estimate together, and PrEP needs estimates together, so that there's a complementary understanding of the mutual interactions between those different interventions. So thanks. And here.
Thank you so much, Clemens. And yeah, thanks to you, Rob, as well, for that section, introducing the condom piece within Spectrum, and also now with the standalone to CNET. Are there any questions? I see there have been questions coming through the chat function. Any questions for these two presentations before I ask our other colleague, Eileen, to present on the key population size estimate? I've seen also a number of questions coming through the chat, so I'm sure people are looking forward to this overview from Eileen around KP size estimates. The common question that has been coming out throughout the different workshops, a more understanding or a better understanding around the KP size estimates, where the data is coming from, where you find it in these tools. If there are no questions, I don't see a hand up. If you prefer to speak and ask a question, you can show by raising your hand, and then we can ask you to unmute. Otherwise, over to you, Eileen, on the KP size estimates. Thank you.
Hello. Hi. Thank you, Lysias, and good afternoon, everyone. Okay, I'll be short. Key population estimates.
Yeah. Looks perfect.
There it is. You see it? Okay,
yes.
Good. Yes. So the key population size estimates have been filled into this new tool upfront, using estimates that UNAIDS has compiled from available country data. Let's see if I can get rid of this. 1 second. Sorry. Yeah. And it's called the UNAIDS consensus estimates. What are they? For 4 key populations, we have compiled these: female sex workers, MSM, transgender women, and people who inject drugs. Essentially, we have looked at what countries have submitted through GAM, which in the case of the European countries could also be Dublin Declaration reporting. This exercise was done in November last. And if that was an adequate national estimate representative of the country and complete, that was used. Some countries had even an epidemic model that distinguished key populations, and where that was the case, we considered that even better, because by synthesizing the various population sizes alongside the prevalence data in an epidemic model, the consistency is guaranteed because the sum of the subgroups matches the national total and like the national program data. This was the case notably for 10 countries in Eastern Europe and Central Asia, for which an optimat transmission model was available. In those cases, we took the estimate of the key population size from that transmission model. Also, there were a few countries that had an EPP concentrated model for their national latest HIV statistics, and those also distinguish key populations. In those cases, that model was used. Then there were many countries without a model or not reporting to GAN, but we found national published population size estimates for the Netherlands, Sweden, UK, Germany, Australia, and Spain, and those were used. That left still a number of countries with no published key population sizes. And for those, we took the regional median of the above sources, so the country data or models available, either from Western Europe or from Eastern Europe and Central Asia, or separately for North America, in fact. And just for background, this does not impact a new tool for your use alongside the estimates this year, but these same population sizes have been used last December in the World AIDS Day report, you see it here, to estimate at global and regional level infections in key populations and how these have moved from 2010 to 2024. So matching national HIV estimates, but then for the key populations. And the same key population sizes and infection estimates are now also being used for the Global Fund Grant Cycle 8 grant allocations. And I'll here show the regional medians. So these were used for countries without a national valid size estimate. As an example, for Western and Central Europe, for sex workers, the median group size was 0.29% of all men plus women. So that will be the same as 0.58% of all adult women, but 0.29 out of women and men summed. So that will be imputed. That's what you would see if your country didn't have a national size estimate. And I'll end with just this link to the key population infection size estimates published in the World AIDS Day report, where it was found that globally, still about half of new adult HIV acquisitions are among key populations as of 2024. And that share even slightly increased since 2010. And outside of sub-Saharan Africa, that pattern is even more pronounced, with more infections concentrated in a key population and their sexual partners. With an special probable rise among gay men and other men who have sex with men. Thank you.
Thanks, Ellen. Thanks for that quick overview on key population size estimates and the links to more information on that topic. Yes, do we have any questions on these three presentations, the condom part and the KP size estimates part? Any questions, colleagues? You have the Excel versions of all these aspects, the KP size estimate that Ellen just showed you now. There's the condom part also. We shared the Excel version. We shared the Excel version of the PrEP as well, the PrEP piece. And then for other regions where VMMC is relevant. And for those who speak Russian, there were Russian versions also shared by Rob in the chat box. Any questions? Feel free to raise your hands or to post in the Q&A function, and then we can follow through your questions. Any questions? Feel free to raise your hands. I'll give it a few more seconds. And then we can go through to another mentee to reflect on today's session after my colleague Clemens. I'll give a few more seconds. Okay, I don't see a question here. I don't see a hand raised. I guess everything has been clear, and maybe more questions will come out as you practice, as you go through these tools on your own. Maybe questions will come up, and feel free when you do that to reach out with any clarifying questions. So before I give to my colleague Clemens to help us reflect on this and link to the GC8 processes and any other processes within your countries, I'm going to do another Menti, the last one for today. Let's just reflect on what we have covered today. A last short Menti, the same site and the same code. If you go to www.menti.com and then you enter the code 44382492, or you can scan. I see most of us, we are still there on the Menti. Can you show by a thumbs up that you are there on the Menti and you are still active? Okay, just show by a thumbs up. I see others are joining now. You can scan that QR code and it will take you to the Menti. May we show by a thumbs up so that I know they are actively participating even from the last Menti. If we can show by a thumbs up on our Menti that we are there. Those who couldn't join before, you can just enter menti.com and then you enter the code 44382492. I don't see a thumbs up here. Can we show by a thumbs up so that we can go to the first question? I want to see how many are actively on Menti. Okay. Let's go to the first question. Yes, I see some that are joining. Yes, thumbs up. I see thumbs up coming. You can still scan that QR code there. You can scan that QR code. It will take you to this Menti. Great. It's good to see many people are joining the Menti now, and I see more thumbs up. The first question is, how confident are you now in using spectrum prevention needs estimates tools? We have gone through the presentation of the overview of these tools. We even covered using standalone tools for condoms and for PrEP. And we have also been shown how to navigate these tools within Spectrum. How confident are we now in using these tools? Yes, 3 so far have responded. Let's keep coming. I see more people have joined the Menti. This will be very useful feedback to gauge how useful you have found these different sessions. How confident are you in using these tools? Yes, I see more responses are coming. I'm going to show the results now, while I allow okay, the level of confidence. So the scale works towards the far right, that's very confident, far left, that's not confident at all. On a scale of 1 to 5, 5 being the very confident and 1 not confident at all. We're at 2. So, okay, maybe some more responses. This is a good reflection to know as well that people are not yet that confident. Maybe more time is needed to reflect on this, to practice more. 1.9, 1.9 out of 5, out of a score of 5. 3 more seconds, maybe 3 more seconds for a few more to reflect, and then we can go to the next question. As I highlighted earlier on, we are going to post all the resources from today, including others from other workshops from other regions. All of them, they are going to be on the Global HIV Prevention Resource Hub. You'll be able to access the resources there. You'll be able to go through the content again there, and you'll be able to practice more there. It would be great if this scale can move towards a score of 5, where people are very confident in using these tools and applying them in your countries. Okay, next question. How do you see your country using these tools or results in 2026? How do you see your country using these tools or results this year? Any reflections on that? How do you see using these tools? Okay, I did not see any reflections on this one. Maybe it's a difficult one. Okay, one, I see one. Maybe the person was still typing here. Maybe too optimistic, but in any case, it is not impossible to try to apply these tools and results. Yes, that's the thinking that we want to hear. It's good to be positive. We will need more consultations in the country before we use it for 2026, not sure. Okay, that's another good reflection there. Yeah, at times tools take some time to really grasp and find their use. The input data you need to gather, maybe as a country, as a working group, look at the default data there, update it, and then discuss how you want to go forward. These are both good reflections. Any other I'll give maybe 5 more seconds for those maybe who are typing. Since this is a text-based question, maybe those who are typing, I'll give 5 more seconds to finish typing, and then I can give back to my colleague, Clemens. Any countries that are doing, who are going to be in the Global Fund processes from the region? It was also our hope that some countries will find this useful for those processes. When you put together your proposals to Global Fund, how do you quantify your prevention needs? How do you cost them? And then putting all that and providing justification of how you go to those cost requests to Global Fund, it would be good to demonstrate that. That was one of the objectives of these workshops. And also in other national planning that you may be doing. We need more consultations before we use. Okay, that's great. So coming from this workshop, it seems people need more time. People need more time to reflect more on these tools and to understand them better. Maybe discuss within your technical working groups and go through again This is great. Thank you for these reflections. I will stop here, check if there's anyone asking any question. Yes, I see one here. I would like to ask whether in the context of EECA, the IBBS is still a viable tool or approach to estimate the size of key populations on national level, considering its financial cost, time constraints, etc. This is a very good question, especially now after a number of changes. I'll give back to you, Eileen, to answer this one, and then after you, if there are no other questions, I'll ask Clemens to come in. Over to you, Eileen. A question in the chat. Eileen, I'm not sure if you can hear me. There's a question about EECA and IBBS.
If Helene is no longer
Yeah,
with us, I can actually also address
yes,
the
yeah,
question. And I typed a quick response into the into the chat in the meantime.
yeah,
I think it's a very good question. Of course, IBBS in principle is very useful and important because it gives us a better, population level understanding of the epidemic and the effects and the outcomes of the response, including the prevention response and of course the behavioral um, situation as well. So in principle, they're important. The question is, of course, the financing source and the frequency. Um, so in an ideal setting, one should do these kinds of population-based survey maybe every 5 years. I mean, one could also do it even less frequently than that if there's no um, resources available, and do something like a BBS Lite in between, or programmatic surveys like on a tablet that is, administered either in a site or by an outreach worker. Um, of course, they will not have the same function. They will not have population level representative. They will just give a perspective on program participants. So I guess there's a full spectrum of options that will depend on the financing. I cannot imagine, based on what I've seen from the replenishments in the Global Fund, that they can afford to keep funding these types of surveys in all countries at the regular frequency. I think it will much depend in future, of course, what the domestic financing is and how we can allocate those. So I see Aline is still there. So if you want to speak to that from a more surveillance perspective rather than my finance and program perspective, feel free to come in, Aline.
Thanks, Clemens. Sorry, please, could you repeat the question?
The question was whether, as IBBS is still viable.
If it's viable.
Yeah. Considering the financial
okay.
costs and time.
I'm not the best person speaking to that. I think in more settings, personally, I think that there will be less IBBS, however good and useful they are. It's inevitable. There is the IBBS Lite now, yes, as you said. That is a good, well, not an exact alternative, but certainly a something. I think the reality is more that we will learn to live without as frequent IBBS as in the past 15 years, and adjust the needs on various ends accordingly. Certainly, speaking from the estimates standpoint, we would not expect an IBBS or a key population size estimate every 3 to 5 years anymore, maybe less frequently, and deal with that.
Good. No, thanks, Eileen. Lysias, with your permission, should we start winding this up, should I close this, or are there any other
Yes.
questions?
Yeah, I don't see any other questions, so I think we can come in, Clemens, for the closing. Yes. Over.
Um, Let me maybe start with a reflection based on this last question on IBBS and survey. So one of the reasons why we have also elevated prevention needs estimates at this moment is because quite a few countries are concerned that their traditional ways of measuring prevention, like regular IBBS or DHS or other population-based surveys, are no longer there. So measuring, condom use and these kinds of behavioral outcomes will be more challenging. And that's why having a good handle on programmatic data, understanding a denominator, establishing a denominator for condoms, for PrEP, for key population program coverage through a modeling process is actually helping us to have an annual target that then we can, programmatically measure. And maybe a second reflection on the survey. It's interesting that in most regions we've had after these questions, how confident are you in using this? We had about 3.7, 3.8 was sort of in most of the regions the average response. So people were not perfectly, but quite confident in using this. I was surprised today it was lower, and that reminds me of maybe a need to adjust either how we present this in this region. Maybe we need to put more focus on the harm reduction needs estimates. Maybe we need to put more emphasis or allocate more time to what we covered in the end, the key population size estimates, how to translate those into programmatically relevant relevant targets. And that is certainly something we can do. And if you have additional feedback, even by responding by email to any of us on how we can make this more useful for this region, and more, and boost your confidence and that this is relevant, that would really be helpful. And we're of course aware that many of you have other modeling exercises ongoing, including optima modeling, where you may make assumptions around the same kinds of issues, population sizes, targets for different products, yeah. So we'd be grateful if you could really guide us further in how to make this routine spectrum needs estimation for prevention also more useful. In this final reflection, I just want to pull up one more slide from the Global Access Framework that is here, and which illustrates on where to go from here with these needs estimates. So after a process perhaps of estimating the need for HIV prevention, and again this is just an illustrative country target table, where you have here on the left side potential numbers of what the total need might be for many of the smaller countries in this region. These numbers might be too large, but it could be of course tailor-made. And then the idea would be that for prevention products, one could think about what should actually be to meet the full need, the segmentation. So free public provision, perhaps subsidized provision, social marketing, where specific players, social marketers or social enterprises could actually try to reach populations with subsidized products. And there could be a share of the private sector as well. Pharmacies, for example, we know it's already happening for needles, and one could try to determine such levels, of course, also happening for condoms. And then the funding source of government versus donors in this region, probably remaining donor mostly might be the Global Fund or perhaps some smaller foundations. And then we have the same for the populations, the key populations, whatever the target might be in line with your country population size estimates. Then what is a programmatic target, for example, for some populations for MSM, one would argue probably that MSM with very long-term stable partners might not need programmatic reach even every year. So you would determine that target and that denominator and the population that needs to be reached, then split between facility outreach or virtual modalities, depending on the context. And then of course, again, a funding disaggregation for that. So that's a frame, a framing for using this. And while you might already be doing some of this, the idea here is to do this holistically for the whole program, and then in a very targeted way identify where there's need for public sector intervention, government intervention, where there's need for actually donor support as well. So that's just a final framing on how this could be used systematically in promoting strong prevention programs. And we do see actually this happening in some settings, but even in high-income countries, we do not necessarily always have this systematic approach to estimating and meeting the prevention need, and using this information to actually plan programs in a structured way. So with that, I think we believe that this is one puzzle piece in promoting this new era of prevention, which is an era of method mix, where we need more granular and systematic analysis of need for the different options in different populations, annual tracking of progress at all levels, not least because the surveys will not be affordable, and these needs estimates, if we have them at national and the district or oblast level, we will be able to track against some headline indicators, whether it's products or people, and overall I think this can be a key ingredient for a revised state-of-the-art country prevention plans, matching PrEP, for example, uptake and distribution to the need. We see fantastic ECDC reports with breakdowns by population, but we don't necessarily see the denominators yet being used in that to say, 3,000 people using PrEP. What does that mean? Is that actually much, or is that very little? And denominators really help in reassessing what certain levels of prevention coverage means, where the gaps are, and how we can move closer to the target. So with that, 2026 can be a year of a renewed prevention push, given some of the new options and technologies we have, and we hope that this session was also giving you some ideas on how data and prevention needs estimation can help advance this prevention push. So thanks so much, and have a good rest of your day.